Hi friends, welcome to Pharmacology. So today we are going to discuss some patient case based, that is clinical oriented type of questions discussion. So starting with today's first question. A 32-year-old man presents to his primary care physician because of a 2-week history of nasal stiffness, cough and sinus pain. He is prescribed with phenylephrine. He must be aware of which of the following potential adverse effects. Options are constipation, diarrhea, epistaxis, hypertension, tinnitus. Epistaxis means nasal bleeding. Tinnitus means ringing in the ears. So here the correct answer is option D, that is hypertension. We know that phenylephrine is a vasoconstrictor that raises both systolic and diastolic blood pressures. It has no effect on the heart itself, but rather induces reflex bradycardia when given parenterally. It is often used topically on the nasal mucous membranes and in ophthalmic solutions for mydriasis. Phenylephrine acts as a nasal decongestant applied every 4 hours and produces vasoconstriction. The drug is used to raise blood pressure and to terminate episodes of supraventricular tachycardia, that is rapid heart action arising both from the AV junction and from atria. Large doses of phenylephrine can cause hypertensive headache and cardiac irregularities. Next one, a 49-year-old man who smokes 3 packs of cigarettes per day for the last 20 years, that is 60 pack years, is currently taking an oral nicotine agent to stop smoking as well as clonidine. Approximately 3 days ago, he stopped taking his clonidine and now complains of a pounding headache. What is the most likely explanation for this finding? Options are development of portal hypotension, development of subclinical diabetes, development of rebound hypertension, receptor hypersensitivity. So here the correct answer is option C, that is development of rebound hypertension. So rebound hypertension is a sudden increase in blood pressure that occurs when certain medications, particularly those used to treat high blood pressure, are stopped abruptly. It's not just a return to previous blood pressure levels, it can actually cause blood pressure to spike higher than before treatment began. This phenomenon is most commonly associated with the abrupt cessation of medications that affect the sympathetic nervous system, such as beta blockers and alpha 2 adrenergic agonists like clonidine. So here the patient is taking clonidine. Okay, so clonidine acts centrally to produce inhibition of sympathetic vasomotor centers, decreasing sympathetic outflow to the periphery. The most common side effects of clonidine are lethargy, sedation, constipation, and xerostomia. Xerostomia means dry mouth. These effects generally decrease with therapy progression or dose reduction. Abrupt discontinuation must be avoided to prevent rebound hypertension. Next question. A 58-year-old man with cardiac dysfunction is placed on propranolol, which is a non-selective beta blocker. Over the ensuing days, he develops worsening pedal edema, and review of his serum electrolyte reveals a serum sodium of 151 milliequivalent per liter. What is the most appropriate treatment for this patient? The options are furosemide, potassium chloride intravenous fluid bolus, sodium chloride intravenous fluid bolus, triamtrene, watchful waiting. Here, the correct answer is option A, that is furosemide, which is a loop diuretic. Reduced blood pressure causes a decrease in renal perfusion, resulting in an increase in sodium retention and plasma volume. So this is the reason for pedal edema in this particular patient. So in some cases, this compensatory response tends to elevate the blood pressure. For these patients, beta blockers are often combined with a diuretic to prevent sodium retention. Hence came the answer as furosemide, which is a loop diuretic, which is often given as a combination with beta blockers in order to prevent sodium retention. In this case, administration of furosemide is the most appropriate treatment. Now, coming to the other options, intravenous fluid bolus will worsen this patient's peripheral edema. Okay, already this patient has edema. So again, if we are giving the fluid bolus, it will again worsen the patient's condition. Also, triamtrene, it is a potassium sparing diuretic. It would worsen the electrolyte abnormalities in this patient. Then watchful waiting will also worsen the electrolyte abnormalities in this patient. So hence came the correct answer as option A, which is furosemide. Next one, a 59-year-old man with Parkinson's disease begins a course of bromocriptine in hopes of improving his significant symptoms of cogwheel rigidity and bradykinesia. After being on the medication for 6 months, a renal ultrasound is obtained that reveals bilateral hydronephrosis and elevation of his serum creatinine to 2.5 mg per deciliter. What is the most likely explanation for these findings? The options are drug toxicity, renal artery stenosis, renal artery thrombosis, renal vein thrombosis, retroperitoneal fibrosis. Here the correct answer is option E, that is retroperitoneal fibrosis. Serious cardiac problems may develop, particularly in patients with a history of myocardial infarction. So, in patients with peripheral vascular disease, a worsening of the vasospasm occurs, and in patients with peptic ulcer, there is a worsening of the ulcer because bromocriptine is an ergot derivative. It has the potential to cause pulmonary and retroperitoneal fibrosis. So, in this patient, the findings of hydronephrosis and renal insufficiency suggest this diagnosis. So, this bromocriptine is an ergot derivative. It is a highly vasoconstrictive alkaloid and it has the potential to cause pulmonary and retroperitoneal fibrosis. Moving on to the next question. St. John's wort, a popular botanical remedy, is a potent inducer of hepatic phase 1 CYP3A4 enzymes. Verapamil and phenytoin are both eliminated from the body by metabolism in the liver. Verapamil has a clearance of 1.5 liter per minute, approximately equal to liver blood flow, whereas phenytoin has a clearance of 0.1 liter per minute. Based on this fact, which of the following is most correct? Options are St. John's wort will increase the half-life of phenytoin and verapamil. Next option, St. John's wort will decrease the volume of distribution of CYP3A4 substrates. St. John's wort will decrease the hepatic extraction of phenytoin. This drug will decrease the first pass effect for verapamil. St. John's wort will increase the clearance of phenytoin. Here the correct answer is option E, that is St. John's wort will increase the clearance of phenytoin. We know that phenytoin is an anti-epileptic drug, also it is an enzyme inducer. So the induction of phase 1 metabolizing enzymes will decrease the half-life of substrates of these enzymes. So here the St. John's wort, it is a herbal remedy. It is a potent inducer of CYP3A4 isoenzyme. So induction of phase 1 metabolizing enzymes will decrease the half-life of substrates of these enzymes. P450 enzyme induction has no effect on volume of distribution. Hepatic extraction, the first pass effect and clearance for CYP3A4 substrates will be increased by inducers. However, the extraction of verapamil is already equal to the hepatic blood flow, so further increase in metabolism will not increase the clearance of this drug. So hence came the answer as option E, that is St. John's wort will increase the clearance of phenytoin. Okay, so here it is mentioned, that is the hepatic extraction, the first pass effect and the clearance will be increased by the inducers. Okay, so hence came the answer as option E, that is this particular herbal remedy, that is St. John's wort, will increase the clearance of phenytoin. So with this question, we have completed today's question discussion series. Thank you everyone for watching this video. Please like, share and support.